Thank you. This is why you get a surprise today. This is why you get a surprise. Oh, yeah. Oh, okay, fine. You guys know your announcements, right? Okay, good. Okay, let's start off with some good news. So, welcome to our fourth general meeting. Okay, it's crazy. The semester flies by. It's already the end of October, November. We have a week off for Thanksgiving, so we only see you for like 3 weeks. And then 1 week in December, and then DDS is done for the semester. And then you guys have your evaluations for your associate membership, for your active membership, for the new members at least, not for you returning members. So make sure, if you are an associate member, you're getting all the points necessary so that we can't, exclude you from DDS. We don't want to do that. So, good news, every month, every mainly active month, September, October, November, and then in the spring, different months, we pick 2 members of the month that are recognized by the admissions office, so they keep your name. And these members they go out of their way to be active members of DDS. And they not only participate in our events, but they also get to know the DDS e-board and become our friends and stuff like that. So it's not just about attending events, it's also becoming a part of the family that we try so hard to, create. So for September, I'd like to congratulate, and if you guys could come up here and grab your certificates, Cynthia and Anthony. And these certificates read, in honor of outstanding dedication, the Delta Delta Sigma Executive Board presents blank. So this is for you. And that's for you. Presents blank with this certificate of recognition for exceptional commitment to the USC Pre-Dental Honor Society, and it is signed by the Dean of Admissions, so it is a pretty big deal. All right, congratulations, you guys. Stick around after, we're going to take some pictures.
Pictures.
That was for September. We also have a couple for October, so we'd like to congratulate Olivia Kramer and Rahul Gupta.
Yeah.
I'd just like to say, it's really rare that we have new members as members of the month. Olivia's been doing an awesome job. She's been coming to mostly all our events. She's an outstanding member, talks to us on e-board. So yeah, congratulations to all 4 of you. Yeah. So, on top of that, the year is coming to an end, and it is time to start thinking about next year. And what I mean when I say that is you guys should be thinking about the future of DDS and next year's e-board. So, you guys should be thinking about what positions you might want to run for because, we need you. And, you guys are the future of DDS. I'll be gone next year. So sad. So sad. Michelle's going to be gone. Most of these guys are sticking around, but still, there leaves a lot of room to be filled. So you guys really should start thinking about what positions you might want to run for. It is a great honor to be on DDS e-board, especially now that recently, this is actually a pretty big announcement, but we have schools all across the nation asking to start chapters of DDS at their schools. So we're talking Florida, Texas, CSUN in California. All these schools want to start chapters of DDS at their schools. So this organization, clearly, it's a big deal. We're kind of a big deal. So, you guys should really consider being on e-board. It is a huge responsibility, it's a huge honor, you're recognized a lot, and you're rewarded for it. So, I encourage all of you to think about that. You guys have some announcements?
So real fast, if you guys are going to be missing a meeting, be sure to email me about it, like the day, preferably before the meeting you missed, but if you email me after the meeting, you're still going to have the same deadline to turn in your meeting minutes. So, like, if you email me 2 weeks after a meeting you missed, you aren't going to get that point. So just make sure to be on top of it and just communicate, because it's cool, we understand that you guys are busy, but just make sure to communicate with us. Thanks, guys.
Also, Julie and I wanted to tell you guys about a nonprofit organization that we're on the board of. The nonprofit organization is called Well Worth we're gonna do a few community service events throughout the semester, a few fundraising events. So if you guys want more information about that, you can there's a website, or you can email me and I can send you guys. We're gonna have an info session in a couple weeks. So
Yeah, you guys should get an email about that in the next few days, just as like heads up. But what it is we're offering under point to whoever joins it in the society, and it's just a really good opportunity. Like it's a non-profit. Like we're trying to like help fight malnutrition around the world. And we'll send out another email about it. We're gonna have a meeting. I think we'll have a meeting like next month, maybe.
yeah.
If you guys want to get on board with it, it'd be really cool.
Cool. Any else? Anybody else? Okay, so in the next couple weeks, we don't have too much going on. The next meeting, which is in 2 weeks, November 12th, it's actually not going to be a meeting. We're having our first workshop of the semester. It's going to be a dental anatomy workshop. We actually got kits where you guys can literally build a tooth from the ground up. So you guys will be given molds where you can craft a real tooth that's anatomically correct, and you'll be guided by some Austro-dental students that are awesome in helping us out. You'll get to work with drills and all these tools that they use. It's pretty awesome. I did it a couple years back. It's helpful. It's very cool. So that's on the 12th. We were going to have our fundraiser on the 15th, but we're no longer having that because of Parents' Weekend, so that's unfortunate. But we will have another social event, so keep posted about that. And, yeah, what's up? No SSE this week. What else? Hygiene. Okay, so for the freshmen and sophomores, if you're above that, you can't really do this program, but there's this thing called Dental Hygiene Pathways Program, and for you underclassmen, it's really good. So if you fulfill certain requirements by your sophomore year, you can apply to this program. It's in Austro, and you start in the dental hygiene program, which leads directly, you don't have to reapply, well, not formally at least, but it leads directly to 4 years at Austro. So what you do is you apply to this program, you do 2 years of dental hygiene, so in their hygiene program, and then they put you right into the 4 years of dental school. So it's a very cool program. It's very hard to get into. They actually, last year, I think every one of us that applied from DDS got in. So they really do, I mean, I'm not going to say they select directly from us, but they do select a lot of us just because they see how hard we work and how good we are in the sciences and stuff like that. So it's a very good program. If you have questions about that, come see me after. There's an open house on November 12th. It's at 6 p.m. If you want more information about that, it's up here with me. So just ask me about it. And then Taylor, quick announcement, and then we're done.
Okay, my name is Taylor Yamanishi, and I'm currently a senior. I'm the president of an organization on campus called Volunteers Around the World. I sent out a little Facebook blurb a little while ago, but I think I'll send out something through the email to all of you guys. And what we do is we go abroad over the summer for 2 weeks in the Dominican Republic and provide dental care to the locals out there. And we end up working with local dentists. So if you guys are interested, I will be sending out information, and then with all my contact information, so just give me an email back. Okay?
Cool. All right, without further ado, I'd like to introduce today's speaker, Dr. Nikchevich.
Yeah, thank you.
Well, guys, thank you very much for having me. Boy, this is a good group. I started my involvement with USC Dental School in 1981. Yeah, it was a while ago. And you guys weren't mostly born by then, I think. And it was pretty interesting because the demographic has changed. The class of 1981 was 130 people, and 4 of them were females. Okay? So this is much more balanced. So nice to see at this point. My name is Don Nikchevich. I am the dad of Nick, who you can see assisting me. Well, since I have a 2-screen deal here, we'll have to use the built-in laser pointer guy here if I can find it. Hold on 1 second. Let's see. Maybe you can see it assisting me in a second. Come on, let's go. This is moving at a snail's pace. Hold on. But you will see Nick assisting me in a second there. Thank you, thank you. He's coming up. I'll just grab the laser pointer and point on one side there. There he is. So that's the back of Nick's head. He's been very good for the last 2 summers. I've woken him up at 7 o'clock every morning and dragged him to the office, and he's joined my team of, I have 30 women that work for me, And Nick has fit in perfectly well. He's a little lazier than most of them, but he does okay. So I'm a board-certified oral and maxillofacial surgeon, and as you can see, that's what I do. I completed my residency in surgery at the LA County USC Medical Center, and so that was back in the day. I attended the Austro School of Dentistry, which was not the Austro School of Dentistry. I can't even remember what the name of it was, but that wasn't it at the time. And I'm a USC undergrad. So I went through undergrad, dental school, and oral surgery here at SC. Loved every minute of it. We didn't have great organizations like this. It was pretty much a hit and miss kind of thing. You were sort of on your own. So today what I want to talk about is my practice, who my partners are, and what I do, just in case you're interested in oral surgery. I'd like to teach you to read a panoramic x-ray. We've got to learn something while we're here, so at least we'll get the anatomy down. I'll give you the scope of oral surgery, and I'll show you some cases. And Nick had me tone this down, and now that you guys are eating, I'm glad I toned it down. Because in oral surgery, we do deal with some strange stuff that isn't usually seen in the dental school here. So we get into some quasi-gross stuff. So it's not bad if you're used to it. Let's see, the gentleman on your far left is Mike Newton. He's my second youngest partner. Mike went to UC Irvine undergrad. He did his dental school at Loma Linda. He did his medical school and oral surgery at USC. And he's doing good. The gray-haired gentleman is Scott Benyon. He's my oldest partner. Scott did his undergrad at University of Utah, dental school at UOB, oral surgery at Vanderbilt. He did medical school at Vanderbilt, and then he did his craniofacial surgery fellowship and taught at Harvard at Mass General. And then the last guy down there, the smaller Asian guy, is my classmate at dental school. That's Wayne Ozaki. Wayne joined me late into practice. I was in practice for about 18 years by the time he crossed the door and joined me. Wayne did his undergrad a couple years behind me at USC. He did dental school at USC in my class, class of '88. He did his oral surgery at Pittsburgh, got his medical degree in Pittsburgh, did general surgery at University of Michigan, and did plastic surgery at University of Michigan. So he's a board-certified oral surgeon and plastic surgeon. And Wayne is presently the head of pediatric plastic surgery and the director of craniofacial surgery at UCLA. So those are my partners. So I'm the undereducated one, but they are fun guys. So this is a look at our office. The left-hand side down there, you'll see our cone beam CT scan. I heard you guys did some 3D CT scan stuff. Somebody was giving you a lecture. That's the machine that gets it. And then that far left photo on the right side is our digital Panorex machine. That's a recovery room up on the top. And down below is one of our front offices. And these are the ORs. So we don't work in dental chairs. We work in operating room tables. That's my big OR in my surgery center that I have. And then I've got 2 of these and 3 of those. And, you know, if you've had your wisdom, just have your wisdom teeth out. There we go. If you do an oral surgery, take your wisdom teeth out. Or did you do it? Yeah, okay. So you probably did something like that. So that's pretty much the norm. That's sort of what we stand. This is a panoramic x-ray. And this is actually me right here. Got a good looking mouth. That was from 2005. I actually have a root canal on that tooth. That filling was done when I was 13 and when I was about 42, which was a decade and some change ago. I had a crown and a root canal, and a crown on that one, and I still have that one from a basketball injury. The little root canal right there. So let me see if I can get this to show up here. Usually it's pretty good at doing it. You gotta love it like that. Come on, I want to get this for you guys because I want you to learn this. So. Yeah. Okay. It's not going to do it. I'll just have to draw it out. You'll have to watch one of these. So I'm going to stand over here for a second so I can see it good. Okay. So if you guys can see pretty good over there, this is a typical panoramic x-ray. This area here is the inferior border of the mandible, so that's the chin area. So if you scratch your chin, you're scratching right down there. This area right here is what we call the alveolar ridge. That's the main bony ridge of the lower jaw that the teeth emerge from. And within the lower jaw, which is all this beautiful gray stuff right here, which is the bone of the mandible and lower jaw, there's a very important structure. Right here is the inferior alveolar nerve. It goes down there, leads from a little hole called the mental foramen. Some of you guys that are in anatomy now are familiar with that. The nerve's about the size of a linguine, so it's pretty big. It's not like a piece of hair. And it leaves the bone right there from that foramen and goes to your lower lip. So if you've ever had any dental work done and they give you an injection in the back of your mouth and your lip is numb, that's why. They don't care that your lip is numb, and you won't care that any of your patients have a numb lip, but it's a good sign that the injection you gave way back here up at the top, over here, where the nerve enters the bone, you got the whole thing if it's numb at the end right here. So that's the mandible or lower jaw. The upper jaw or maxilla comes across right here. That's the alveolar ridge there. And there are no big major nerves in the upper jaw. What we do have is a sinus. That right here is the maxillary sinus on the right side. This is the nasal cavity right here. So if we were able to draw that out, it would start looking like a skeleton. And this is the sinus over on this side. Eyeballs are up here, and eyeballs are up there. Okay? So all this wonderful bone right here is the maxilla or upper jaw. Now, I'm showing you that because we're going to look at a bunch of x-rays as we go here. And I want you to at least have a bearing as to what we're looking at. So everybody's good with that? All right? Oh, comfortable. So that looks like a good place to start. What is the scope of oral surgery? Anesthesia, that's the first one that we'll talk about. Extractions, trauma, pathology, and reconstruction. That's pretty much what we do on a daily basis. Right now, the oral surgery program at SC is directed by one of my classmates, Mark Urata. Mark and Wayne are sort of like equals. My partner Wayne and Mark were sort of in competition. I think Mark did all his stuff at USC, and when I added it up one day, he was at SC for 24 years. He did undergrad, where he was in the band. He did dental school. He was my subservient in oral surgery for 4 years. He went to medical school. He did general surgery at SC. He did plastic surgery at SC. The only difference is he did craniofacial surgery at UCLA with Henry Kawamoto. So then now, Mark right now is the head of plastic surgery at USC. He's the head of oral surgery at USC. He's the head of craniofacial surgery at Cedars-Sinai and at Children's Hospital. So, overachievers. So if you want to get into oral surgery, you're just starting right now. You know, there's a little bit of education ahead of you. Anesthesia-wise, we're licensed by the state of California to perform anesthesia and operate. And so the one thing, there's 5,000 board-certified oral surgeons. The greatest honor that we have is that we are the only people anywhere in the world that are able to put somebody to sleep and work on them. You're a heart surgeon, a brain surgeon. None of those guys could do that, but we could do that, which is something that we have to be proud of. And so we have a very, very, strict overseeing. I actually go for the state of California, for the state board. I actually go into oral surgeon's office and I test them every 5 years to make sure that they're doing the right stuff and that they're using the right equipment and that their assistants are well trained. So that's a real big deal. We do IV sedation and ultralight general anesthesia, and if you had your wisdom teeth out, that's sort of what you had. You got an IV, you went to sleep, you woke up, the teeth were gone, and everybody was happy. We're CPR certified as well as ACLS certified, and that's advanced cardiac life support. And most of us do ATLS, which is advanced trauma life support. So we get all sorts of fun stuff, and I've been a CPR instructor since 1984, and that's when I was in dental school. And I've been an ACLS instructor since 1991. So I've done that a lot. And during the 3 months to 6 months of your residency, you actually act as an anesthesiologist. So if you get into anesthesia and you like that when you're in dental school, that's a good thing with oral surgery. I'm at county hospital and everybody thinks I'm an anesthesiologist. And somebody's having a kidney transplant, the dentist comes in and puts them to sleep and does their job, and they did no difference. So it's pretty cool stuff. So that's really our mainstay. I mean, that's our bread and butter when it comes to it. What percentage of teeth? We do extractions, lots of extractions. I've probably taken out 70,000 plus teeth. I couldn't even, there's days where I took out 100 teeth in a day. So I mean, it's like, so it goes. But what percentage do you think are taken out by oral surgeons? So is it 90 to 100%? Raise your hand. 80 to 90? Oh my God, we have the geniuses. Okay, I love it. Well done society here. 50 to 60? No? 20? 10? 10%. 20? 20? Okay, who says less than 5? Raise your hands. It's less than 5. Come on, there's got to be somebody. Who's brave? Less than 5. Nobody? Oh, Nick, you don't count though. Somebody else. Somebody give you an Apple gift card. If you get it right. So you're going to do less than 5? dental dentists and there's 5,000 oral surgeons. So when you just do the math, it doesn't take much to make that happen. Mostly what we do is wisdom teeth and general anesthesia. So if somebody said, you know, how many teeth have you taken out under general anesthesia, that changes a lot right there. And we do a lot of emergency extractions, and we get all the difficult ones. So we get a lot of calls at 3 o'clock, 4 o'clock, 5 o'clock, where somebody has worked 3 hours to take out a tooth, and then they walk in, and then we get to try to save the day. So that's the good news. This is my nephew Matt, and these are his teeth. And again, just a typical set of impacted wisdom teeth. You know, when you look at this, again, we're good with the, let's see, where's my little guy going to go off there now? Yeah, we're good with the mandible right here, coming right down across here. And you can see these are horizontally impacted wisdom teeth right there. So that's sort of the typical. The next more typical one is this, and the least typical one is a distal angular impaction like that. So he's got his upper wisdom teeth, lower wisdom teeth on both sides. And when I took out Matt's teeth, Matt did his MBA here at UCLA, he was at USC, he was a UC Santa Barbara water polo player. Real smart kid, you think he's an idiot. He's so dull when you talk to him and everything. The stuff that he's achieved is just amazing academically. So he's pretty impressive, but it probably took like 15 minutes to take out his wisdom teeth. So that's usually the normal thing. Now, I don't take out a lot of wisdom teeth anymore. As a matter of fact, Nick's teeth that I took out like 4 years ago, I don't think I've taken out 3 sets of wisdom teeth since then. Nick does, most of my partners take out 10 sets of wisdom teeth a day on a busy day. I just don't do that anymore. So my practice is totally dental implants and reconstructive surgery. So because I have so many partners, I'm able to do different things because they're here to make that happen for me. So we'll see if we can get that. Okay. So trauma, we do alveolar fractures and avulsed teeth. Those are people that get them knocked out in baseball games and stuff. We do facial lacerations, mandible fractures, ZMC fractures, which are zygomatical maxillofacial complex, which is the cheekbones, and we do orbital fractures. So you're allowed to do all those with just a dental degree. So all my partners have like 1,000 degrees. I just have one, and I get to do all the same stuff they do. So it's sort of cool. I didn't have to go to school as long, too. And that's sort of the nice thing about it. Right here, everybody wants to work. A little fracture on the lower left there that you see. You can see the 2 teeth right there, how different they are in size. And we'll show you that in a second. We'll give you a 3D image because now everything we do is 3D. On this 3D model, you can see the break in the angle. That's an angle fracture. You can see the 2 teeth in the back, how they're different in size like that. So that has to be reduced. And I'll show you how we reduce those in just a second. We have some good ways to do that. Here's another fracture. You can see it right down the center there. And there's also a condyle fracture. If you look at the upper right side up there, you'll see that condyle, where the temporomandibular joint is not in the right spot. And so we'll show you that in 3D too. It becomes a lot more obvious. There's the midline, what we call the symphysis, or the parasymphysis, which is between the mental foramen right here. And you can't see the condyle real well there, but you'll get a view of a normal condyle here in a second. Normal condyle right there. So that one's good, even though it looks a little moth-eaten. That's just what happens on the 3D rendering of it. And then you'll see its buddy next door isn't looking real good. There it is. It's sort of lopped off right there, so broken off. So believe it or not, a condyle like that, you don't have to really set that back into place. Okay? As long as the patient's not real young, you can actually live with that. And as long as they have full range of motion and they're able to open and close, you can leave stuff like that. Those are the hardest ones to reduce. And a lot of times you run into residents that try to get those, and they dig a big old hole and they get nowhere. So a lot of times we'll just leave those alone because there's not enough to fixate right there. So that's part of the trauma we see. This is a young guy, my newest associate. I have an associate too, John Shoddy. John is a UCLA undergrad, USC Dental School. He's really young. He's like 31 or something. And then he went to Fresno to do his 4 years of oral surgery. This is a little guy he treated that was bit by a dog. And so, you get a dog bite and things like that. And, that's the kind of stuff that we see. And when you do your residency, you do lots of it. And hopefully when you're in private practice, you do none of it. Because it just keeps you up all night long working. This guy has a lot of fractures. You can see that he has breaks everywhere. We call that a pan-facial fracture. And Nick told me to leave out all the good stuff, so basically all the skin is pretty much gone. So I'm just showing you the x-rays because you guys ate too, so that would have been a bad thing, I guess. But you can see how many fractures are there. And then you'll get to see how many plates had to be put in to put him back together in just a second. So that's how many plates he got on x-ray. So the plates we use are usually titanium plates. They use little bitty screws, titanium 2mm screws, and basically it's like a little jigsaw puzzle. It becomes very boring and dull because you're there for 12 hours doing that kind of stuff. But you know, it's what you do. It's fun, you know. What you doing back there? Okay. All right. So anyway, if you look down on the lower here, you can see these two plates right here. We have two more compression bone plates across this fracture. And then you can see this mess right over here. We don't do braces on people. We do something called an Eric arch bar. And I'll show you what one of those looks like in person here. This is about probably the grossest slide I'll give you. This is the Eric arch bar. It is not braces. What happens is we run one 26 or 24 gauge wire around every tooth and twist it to the arch bar. And then you got that arch bar, one lower one with lugs coming downward and an upper one up there with lugs coming upward. So you can wrap a wire around it and put the upper and lower jaws together. Once the bite is fixated, then you can put the bones back together. So you can't put the bones back together and not have the bite right. Otherwise, when they're all healed, they don't bite right. Their teeth are all cattywampus. So the first thing you do is you get the teeth together correctly, and then you go ahead and do the bone. So that right there is for another card. Anybody? Anybody? Yeah, that little spaghetti linguine coming out of it. The mental foramen. Oh my God, I'm impressed. Right, so very good. You guys should get a card for that one because I told you that. I hope you have iTunes. You do. So basically, what she identified correctly from hopefully a good anatomy class. This is the mandibular lower jaw, Eric arch bar, upper teeth and upper lip are here. Lower lip is pulled way out of the way. Bone plate here, bone plate here. That's the inferior alveolar nerve. That's the main sensory nerve of your lower jaw that we drew out on the Panorex. And that's where it comes out of the bone right there and goes to your lip. Looks like a little oak tree when you dissect it all out. But it's big. Nothing is small. You know, there's no little pieces of hair or something. Everybody thinks these things are little. And nerves are very tough. To cut a nerve, you actually have to go at it with a knife and work at it, okay? They don't cut very easily, which is a good thing. But that is the mental foramen and the mental nerve right there. So how'd you know that?
You said that.
Future oral surgeon there. Yeah, there we go. Okay, I like that. So we do pathology. This is the side of somebody's tongue. They've got some white whatever on it. Probably a benign keratosis, just nothing they were chewing tobacco or chewing their tongue or doing something. But so we do biopsies of those areas. And we do bony biopsies, soft tissue biopsies of the head and neck area. So that's sort of part of the course there. And then we do alveolar reconstruction. So that's what I do all day long. And it's either tissue grafts, bone grafts, or implants. And what I'd like to do is just go through a couple cases and sort of give you some insight as to how we do some of these things. There's an Eric arch bar again, right there. So you can see how each wire is put around each tooth to hold it in place. If you get really fast at it, at County Hospital we do like 25 a day. And I think my fastest one was like 21 minutes start to finish with a wire around every tooth. And that was like a record for a long time. I don't know if you really get to the point where you really can't go much faster because you're shoving the wire, you bring it around, turn it, shoving the wire, turn it, cut, and away you go. But you can see that patient's teeth didn't come together real well. Okay, so she needed some other surgery down there. This was one of my patients that was kicked by a horse. That's her x-ray. She lost all those teeth. This is what she looked like before we did the reconstruction. And this is another guy that was congenitally missing some teeth that we'll talk a little bit about. So I do something called distraction osteogenesis, which a lot of people don't do. And it's just, I don't know why I do it. It's just something that I thought was fun and it worked. And so I've had great success with it. So you guys are going to learn a lot more about it than most people in dental school know. Believe you're experts. That tooth over there was knocked up there in an automobile accident. He got hit in the tooth and drove it right up in the steering wheel, and they couldn't pull it down orthodontic. So orthodontist is pulling. You see he has braces there. This has been like years ago, can't move it. So what is the option? Take the tooth out or do something fun. So what we ended up doing is doing a little distractor on it. And you see that little nub of a thing up there on the upper left? That's the little nut for the distractor that turns it, and I'll explain it to you in a second. But you see how we were able to bring the teeth down and level them off, and the gum tissue's even, and everything looks good? So a much nicer alternative to doing some of the other stuff. So here's sort of a before and after kind of thing. This is a different guy. I don't know why everybody does the same tooth up there. It's like I have like 50 guys that all have their left tooth. It must be something when you're in an accident, you turn your head or something. I don't know, but everybody does the left tooth. Because this is obviously somebody different. This guy has a beard where the other one had, no beard. But you can see the tooth and how high it is. And in particular, you can see the gingival margin up here. Those are not good, right? And then when we're all done, you can see that they're even, okay? So I'll show you how we got to that. Now, orthodontists were pulling on that with all sorts of rubber bands like you guys have probably had, but to no avail. So there is a way to do that. So the distractor is this little guy right here. He's basically starts with the two plates together. We go ahead and we make a cut of the bone all the way around here. And then we have this screwdriver that you send them home with. And they actually turn the screwdriver 3 times a day. Okay? And you're able to move the bone 1 millimeter a day. So if you move bone at 1 millimeter a day, the bone will fill in as well as the soft tissue will grow as well as the muscle will grow. So, our big problem is if you have a big hole, where do you get the gum tissue to cover it up? This way you grow the whole thing as you go. Okay? So that's called distraction osteogenesis. This part of the top, this guy here, that's the transport segment because that's what's being transported. That's the transport plate because it's on the transport segment. The air zone right here is where the bone's going to grow, so that's the distraction zone. And this is the base plate and the alveolar bone down below that holds it there. So I'm going to have to take me a couple times to get through this because there's a bunch of arrows there, and of course this doesn't want to get through all the arrows. There we go. Okay. So this is a 21-year-old, status post motor vehicle accident, fractured mandible, avulsed and impacted fractured teeth, and orthodontic attempts to reposition the teeth were unaffected. So that's what she looks like. And she's got her Eric arch bars on. You can tell that her bite doesn't look all that fantastic, and when she smiles, there's a big opening there. Okay? So her immediate treatment was to put this bone plate in at the bottom and to fix the bone. And that was done by somebody else, and they didn't do a good job of getting the bite, unfortunately. So she had that open bite. So what we ended up having to do on her was take this plate out and do orthodontic surgery on her. So we made some cuts that we call bilateral sagittal split osteotomies intraorally in her mandible. And got the whole jaw to be a separate piece, and then use some little screws to hold it in place. And I've eliminated those for you, but that's, and you can see the tip where the arrows are, how different they are with regards to the tip of the teeth. The one tooth was impacted like everybody else, another left-handed side tooth there. And this is her with the plate in place. And here we come with the distractor. You can see the radiograph of the distractor right up here. You can see the big wee-wah on the wire, how far off it was, and you can see the 3 little screws that go through. We do percutaneously. We make a little incision on the side here. We stick the probe guard through, and you stick the screwdriver through their cheek, and you put those 3 screws in to hold the bone in place. So pretty straightforward stuff. And here's the distraction period. You can see that those 2 levels of the teeth are coming together a little bit better, and now we've got them even. So we did our job there. And you can see that now all of a sudden everything's starting to balance out. And you can see she's got a space down there, so we put an implant in on that lower. We put an implant in the space on the upper, and we have repositioned the tooth into the proper position right there. So that looks pretty good. So this is her afterwards. Much better smile than she had to start with. And if you look at where her front teeth were as to there, so that's good stuff. We like that. And obviously that's a crown on that implant that you saw. Let's see if we can go back there without causing a lot of havoc. This right here is an implant, and that's the crown on the implant right there, and that looks just like the other one, so we can do some pretty cool stuff with dental implants. And that's what Dick unfortunately does all day long when he's working with me, is watch me put in implants all day long. So I put in close to a little over 1,000 a year. So you don't find a lot of people that do those kind of numbers, and I'm just lucky to do that because I have partners doing all the other stuff. And then we've got all the rest of the teeth right there. So let's see what we can get there. Okay, so this is another patient. It's a physician's wife, and you can see her sinuses that we talked about. Big sinuses, very little bone right here, right? Not a lot of bone height here, not a lot of bone here, and not a lot of bone height here. So on this patient, what we needed to do is she's been wearing a denture. She's a very beautiful lady. And she was probably 55 when I did the surgery. She'd been wearing an upper denture since she was 25. So a lot of places, you know, we're all from different places here, but if you grew up in the Midwest in the 50s, they were real big on taking out teeth. So it was like, oh, your teeth aren't real good, you got a couple cavities, just take them all out. Okay? And I was like, okay, that's nice. So I have a lot of patients that are very pretty ladies that are in their 50 to 60 range who have never had upper teeth. You know, they lost them when they were pretty much your age. You know, just imagine that. That just really sucks. So we don't do that a lot, but it was in the textbooks at the time, and people allowed that to happen. So we're going to keep her lower teeth. We need to add implants down here and here, and we needed implants all the way across there, but there's not enough bone for it. So to do this, we're going to take bone from her hip, which we're allowed to do, put the bone in the sinus there, bone in the sinus there, onlay the bone here and here in little chunks, let it heal for 4 months, and then go back in and put her implants in. So that's her hip. Okay, I'm not skinny enough, but if I was skinny, if you feel this bone right here on your hip, that's your anterior iliac crest. Okay, so if you were like wearing a cool bikini, you actually weren't fat like me, you would actually see this bone right here. Okay, and that's where that little X is that bone. So just to give you an orientation. And what we do is we make an incision there. And even though she's nice and skinny, we all got a lot of fat right there. That's pretty normal. And then you just work your way down to the bone, and you get a chunk like that. So that chunk is probably about that big. Okay, it's not like a little piece. It's pretty big. And it's pretty thick. Okay, and then by doing that at that area and doing the inner table of the hip bone, so if you guys have taken anatomy, you don't get a scar. So when she wears a bathing suit and stuff, nobody sees anything. And you don't have a bony defect if you took it from the outside. So we get a bunch of bone like that by scraping it on the inside. So you got these nice little curettes, they're like little spoons, and you scrape away. And then you got a bone mill. So any of the chunky parts, you shove in that bone mill, which weighs about, it's about this big, weighs about 30 pounds, so it won't go anywhere. You shove the bone in the top where you see it, you crank it, and the little particulate bone ends up in that little left-hand guy there. There's a little screw-on thing. You pull it out, and it gives you this really cool bone. And that's a fun job. That would be Nick's job. Nick, go crush the bone. He gets to sit there for 4 hours. So it's like a Cuisinart kind of thing for bone. And that's where it's not going to be my job. So that's where you get the bone all nicely done like that. Okay. So that's all sewn up. And once that heals, you won't even see it there. It's just a little white line, and it's not something you'd even notice. Okay? So, getting into the mouth, this is her upper jaw, looking at the palate from her toes, looking up her nose. And you just make an incision all the way around there, and that's the bone. You can see that ruler that we've got there. If we have the lights off, you know, this is like, that's like 2.5, 3 inches right there on the ruler. So, you know, pretty good amount of bone. It's not like little pieces or anything. That's okay. We're good. And this is how we screw the bone in. So we put the bone in, take those little pieces, put little screws right through it, and hold it in place. And that's going to fatten it up there. And this is on the lower jaw, putting the bone in, screwing it in. And what we've done is we've gained height and width. So now you can see all the little screws holding it in place. You can see that the sinuses are now filled with bone. All the way up there, and all the way up there, and you can see that these little screws are holding that bone, onlaying it onto the side there. So what we'll end up with is a lot more bone than we started with, and then we can put these implants in. Now, since I love these little distractor things so much, she needed to have one of those because she's paying me that money, she needs a distractor. So you can see that center one right there. What I didn't like was the center of her jaw, even though we grafted it and made it thicker, it didn't come down enough. So we did a little distractor on that one, and we're able to then put implants in those various areas. And we can spend 6 days talking about implants. So that's her smile, and this is fixed in place now. Okay, so when she smiles and eats, this is her with her fixed teeth. So she went from wearing a denture to having fixed teeth on implants that work just like her regular teeth would. She can chew and eat anything she wants. You can see down in the center, those are her remaining teeth. And you can see the back teeth are longer because with all that bone loss she had, you got to compensate somewhere. But that's what we got for her. And I actually did that case. I just saw her recently, because my partner is a plastic surgeon and he does all this Botox and stuff like that, she was just in getting some of that stuff done. I did her case about 15 years ago. It's absolutely perfect. Nothing has changed. We're really blessed that that worked out well for her. Vertical ridge augmentation is the hardest thing to achieve in bone grafting, and that's making something longer. We can make everything fatter, but it's hard to make it longer. And so the distraction works really good. This is my buddy when she was 28. Right now she's a mom and she's 39. But when she was 28, she was a teacher, a physics teacher up in Ojai, and a horse riding instructor. And she was standing behind one of the horses and it kicked her and it knocked all those teeth out. So all the way up to the orbit of her eye, you know, that gets into a whole lecture that if you don't eat, I can show you. But we'll show you the better part. So this is what she ended up with after all the healing was done, and she wanted to obviously have something fixed there and not something removable. So again, we went through the motions of opening up that little area. You can see that little plate right there. That's one of the original plates and screws for everything that was being put together. So we just leave that stuff alone if it's not in the way, and it wasn't in the way. And we used my favorite saw, which is an oscillating saw. If you grab that saw with your fingers, it does not hurt you. It vibrates like it's like a sonic hair, basically. The tip of it would not be a happy thing, but the tip is that little part hitting the bone down there. But it works really well to make very, very fine lines, almost the thickness of a playing card. Okay? And there's a distractor right there. And we got our little distractor coming. And we actually did two on her. So you can see there's two next to each other. To give you a rundown on this panoramic view, again, we've got the mandible down there. We've got two bone plates where she had originally had the fracture. Two implants with teeth across it making a bridge. Two distractors that are going to bring all that bone down. And these are the plates. This is at the floor of her orbit. Excuse me, when she got hit, she actually blew out the floor of her orbit, which is very thin bone up there. It's like an eggshell thickness. And if you get hit by a baseball in your eye, it needs to go somewhere, right? So it drops down into the sinus, because that big air-filled sinus down here, it only has a little bit of bone up at the top. So that trauma has to go somewhere, so it drops down. So what you have to end up putting is either a piece of Teflon or a little titanium plate or something in there to be a new floor of the sinus, floor of the orbit, excuse me, to keep it out of the sinus. So in this instance, that's all the hardware, and we did these two distractors to bring the bone down for her. And that's just a messy picture of a lot of stuff. But anyway, so that's where she ended up after the first phase. Big gap turns into a little gap. Again, it wasn't good enough. It really didn't do, it never is good enough. You know, if any of you go into any kind of reconstructive dentistry or surgery or whatever, you're always going to have to do more than you think. It's just the nature of the game. So you can never get it right the first time. So I didn't like it in the center right there. Oh, look at that, I'll probably blind myself. So we had to end up taking these two distractors out, even though we closed that down considerably, and we needed to do another one right there. So that's what we did. And so there's a third distractor we did on her, and now you can see that that gap is really closed down. So we're going to have long teeth, but we're not going to have crazy long teeth. So that's her with her final teeth in up there. And you can see her implants. All those little nice little rod-shaped guys right there. One of them we didn't use right there because it just wasn't in a perfect place and we had enough to do the job. But she has fixed teeth. Now with her, she was a professional French horn player. And obviously without teeth, she can no longer play the French horn. So the beauty of this is I see her every year for a follow-up, and about 3 years ago, she started playing again, and now she's playing professionally again. So we never thought that was going to happen, but that was just lucky that we built her enough of a foundation with lip support, which is really important, I guess, in the French horn. I'm not a musician, but she didn't think that was ever going to happen. So there's her smile right there, and there's her teeth, and that's where we started. So now we do get bone from other places. This is we get in a bottle. That's the easy one. I like it when it comes in a bottle. This is freeze-dried human bone or freeze-dried bovine bone. So the difference in grafts, bovine bone is cow, so it's a xenograft, it's a cross-species graft. Bone in a bottle could be an allograft, like Puros, which is somebody else, same species, just a dead person, obviously, that's giving up their bone. Or we get it from the hip, like I showed you, or from the knee. And so this is the patella, so the bone, the rest of the leg would come here, and the head would be over that way. This would be the patella tendon. This is the tibia right there, and the fibula on the side, and that little guy there is Gertie's tubercle. And Gertie's tubercle is if you have, who has shorts on? Who has shorts on? So it would be a little lump right on the side, right there. Okay, so that's where Gertie's tubercle is right there. And we can actually get bone out of that area. And it doesn't hurt you, and you can still walk and everything. So there's a side view, that's where the incision is made. And then we just make a little incision, cut down to the bone, and start scooping again. And what happened there? So, and that's when it's all sealed up right there, just a nice subcutaneous suture, and life is good. So, and you don't have to do this if you go into dentistry. You just need to know it's an option for you guys. You know, if you like it, then it's somewhere else you can go. And that's the amount of bone we get out. That little dish there is about this big. It's a little stainless steel, like a Dixie cup. And that's how much bone we can get out of that area, which is pretty good. And here's a fun case. And I'll be done in a moment, so because I know you guys have better things to do. This is a tooth that was broken on this guy and was traumatized and ended up having resorption in the side. So real quickly, resorption is when your body starts eating up the tooth. So your bone on a daily basis eats bone and makes bone, right? It's an osteocyte, it's an osteoclast, an osteoblast. Sometimes the bone sees the tooth. It's not supposed to. The tooth is a gomphotic joint. It's actually a non-movable joint where there's bone, a periodontal ligament, and a tooth. So when you have trauma, like baseball hits you in the jaw and either knocks the tooth out or does something to it, the bone then sometimes no longer has a ligament between, and it starts eating everything up. And as it starts eating it up, it makes a big black spot on the tooth like that. So this was a sort of cool one, because definitely you don't see a lot of this. You can be experimental. A good friend of mine is the dentist in Malibu did the restorative on this. So we take the tooth out, which is sometimes is a 5-second job, and sometimes it's a 1-hour job, but got it out, no problem. And then we go ahead and look at the tooth, and you can see that black part of it. And you can see the black part on the side, that's where the hole is in the back that you see right there. And we go ahead and drill our little hole for a dental implant immediately placed. And we do 90% of our implants. We take out the tooth, put the implant in at the same time. And this is all under local anesthesia. I mean, I do 6-8 implants a day. Nobody feels a thing under local. They leave. Every night I make a phone call, and my patients tell me that was easier than having their teeth cleaned. I mean, I hear that 4 times a day, every day of my life. So this is not a big deal. This is actually pretty straightforward. So put the implant in, and we put a little mount on it so that we can actually make an impression at the time of the surgery. And that's our little impression that we use some Duralay, and you guys will play with that probably at some point. And we made it temporary. So tooth came out, the implant went in, temporary went on. Okay, that's not the cool part, because that's just the daily occurrence. We do that all the time. And then it heals. So this is in the healing phase. You can see the gum tissue looks nice and pink, temporary looks good. Not as cool looking as the other teeth, but it passes. And they only have to have it for 8 weeks. I use an 8-week healing protocol. And then we took this guy's tooth, okay, because his tooth had so much characterization in it, the dentist says, I'm just going to take his own tooth, and using bonding agents, I'm going to make it into the final restoration, okay? So that's bad for dental labs, because there goes all their fees and everything, but sort of different. So he took that tooth, and using the model that we created, he made that into, and he's a pretty neat dentist. He's in his late 60s, and the guy's an innovator. So that's what he made using a coping, which is the metal part, bonding material, and the guy's tooth. So he made him his own tooth as the final restoration. And that's what it looks like. That's my buddy Dave Niebergall in Malibu. So we took out the temporary. You can see the gum tissue looks nice there. It's ready to accept the final tooth. And then we put the final tooth in, and the gum tissue's a little off, but it'll heal in a second. Yeah, you got a lot of plaque there, huh? So there it is there. And let me just see if that would, there's a little screw hole in the back. And there it is. Now, the key here is, again, if you could really see this, all the little craze lines and stuff on this tooth that exist. Can you turn the light off just for 2 seconds, or does it not go off?
It goes off.
Yeah, just for 2 seconds. I just want to show you, because it is sort of a funky thing. There we go. So you see all these craze lines in the teeth like that you naturally have? That's what's really hard to replicate. Actually, there's a new way to do it that's pretty insane, but that's why he wanted to go with that tooth. And you can turn those back on. So he actually went 6 years with this tooth before it broke. Okay, so that was pretty cool actually. It's using his own tooth as the final restoration. And then that took care of it, so it looked good. So a great example. So You should feel comfortable looking at panoramic x-rays, right? We're good with that. We knew where the mental framing was, so that's exciting. We should be able to understand using a distractor to recreate an alveolar ridge, right? So you got that down. And know how many millimeters does one turn of the driver would with? For a car, who has the answer to that? One turn. Yes.
Third of it.
Oh, awesome. Oh my God. Thank God there was no women competing with me back in the day. I would not have a job. There you go. Oh, very impressive. All right. So third of a millimeter. That all came from Dr. Lazaroff, who was a orthopedic surgeon in Russia. And what he did was he was treating dwarfism because the dwarf body is pretty normal shaped, but the legs are short. So he had come up with an idea that if you cut right across the femur and put this big halo device on it, if you went a millimeter a day, you can actually gain inches in their height. And so that's what he was able to do. So, and oh, for one more card, what is the protuberance of bone that that young lady has on the side? What's the name of it?
Gerties.
Yeah, who's the Gerties? Gerties tubercle. Oh my God, way too much. Here, throw that back to him. Yeah, those are those fun things that you need to. Okay, excellent. Gerties tubercle. Yes, thank you, and I hope you guys.
Alright guys, just a couple of announcements before you all leave. So, like I said, the next meeting, in 2 weeks from today on the 12th, it's going to be a workshop that's led by dental students. We only have around 45 spots. We're going to have it in the dental hygiene lab. So as soon as you get the email from Nicole, sign up for it. There are limited spots. You will get a reminder email about it, letting you know to be at your computer at a certain time. So just sign up for it on time. Yeah, it won't take the first 45.
But it's not going to count against me.
Yeah, it's not like a real meeting, so you won't get a meeting point if you aren't going. So yeah, it's just a workshop for you guys and stuff like that. So it should be good. Yeah. Any other announcements? Oh, also, I'm finishing my research position, so I actually work with Dr. Urata.
Oh, you're kidding.
Yeah, so he's one of my research
Poor guy.
professors. Yeah, he's awesome. I like him.
He is hilarious.
He's nice. So yeah, it is a really awesome position. If you guys do commute, because it is at Children's Hospital Los Angeles, and you guys are dedicated and committed, this is an awesome opportunity for anybody that wants to do research. So I'm giving it away to you guys, rather than you guys had it than anybody else. So come talk to me about it, alright? Alright, thanks.
So Dr. Urata, oh, you have a question?
What's up?
Oh, for the scrubs, we put them on the
Yeah, the scrubs are ordered. What's going on with the crew necks? What's going on with the crew necks? They'll be here. The crew necks will be here. The scrubs are already ordered, so if you ordered scrubs, they will be here as soon as. Yeah. Any other questions?
Also, if you want more food, you may have grab it.
That's why I got really excited about it.
I almost did. I was like this close to doing it, and then it was going to cost me an extra year, so I didn't think I did guarantee myself. Yeah, like a while ago. It does. It's a really cool program, but like you have to do certain requirements. Like it has its own programs, so it might be too much economics. I'll see you guys later.
Yeah, I don't know. He'll be eating after that, so that's why I told him.
Later, Mike.
You know, he's the little one that's old enough to go to school. I don't want to go to school where it's